So I'm on page 14. So almost always, if we are going to add insulin to a type 2 person's regimen, it's going to be a basal. There are a few times when we'll do bolus only, but it would be rare. So the usual is we add a basal. And when we do it, we usually add Lantus, Levemir, or NPH. You could do Tresiba. I don't know that I would start, but you could add that. Usually we start at about 10 units. If you look on the next page, this is out of one of the consensus papers. This is really good. This is pretty much how I did things, and I think how a lot of people who work with type 2s and insulin did it, and eventually they put it together as a document. So a lot of the reasons for the 10. Now these folks have very high resistance. 10 units is like spitting in the wind, okay? I always tell patients, more than likely this will do very little to your blood sugar. 10 units is a good place to start because they're not going to usually they will not get into trouble. And when I mean trouble, they're not going to go too low. They can start to adjust to injecting themselves, getting used to that approach without getting too low. Okay? So it's just a place to start. The other is that you never know how insulin sensitive somebody is. I have burned 2 patients by going too high, too fast. I started to say I've been burned, but I didn't burn me, it got them though. So 10 units. Some people will, let's see, we used to put a unit per kilo down here. Oh yeah, or 0.1 to 0.2 units per kilo per day. So if somebody weighed 7 kilos, that would be about, or 70 kilos, that'd be about 7 to 14 units. So that's why that 10 is easy to remember. So we start with 10 units a day. Most of the time we will have them, well, I shouldn't say that. You can have them injected any time of the day as long as they can be consistent. When Lantus first came out, we were like, always take it at bedtime. Well, there was reasons for that, but I'm telling you that I wouldn't do anymore. Here's what I do, is I talk to them. I talk to them about when would be the best time that you could remember to inject consistently every day. And I start there. If there are high blood sugars in the morning that I'd really like to get some power out of that insulin, I will see if I can negotiate it at bedtime. And if not, if they say I'm best in the morning, then that's where I start. For a lot of patients, I'll start at noon, especially those that don't work. Because what happens is I get good coverage throughout the day, and if the insulin will not last 24 hours, then by the time they get up in the morning, I've got other drugs they're going to take. So for you to remember, once a day consistency is best. Okay? Then you're going to titrate it. You can titrate insulin every 3 days as long as the person's fairly consistent. Consistent in their routine, they eat, they're not really wild all over the place. Bipolar patient who was hypomanic, I would probably do something different. So what I'm going after is consistency. So I put down 2 to 5 units a day. They have on theirs 10 to 15%. To me, that's too hard to remember. I wouldn't do that. 2 to 4 units once or twice weekly. So that's that every 3 to 4 days. So about every 3 days, I will change it. Here's what I use that I think is the simplest. If their initial response, and you're going to monitor their morning blood sugar, the fasting blood sugar is what you're going to be looking at for this insulin. Okay. So I'm going to look at their fasting. If they stay consistently above 200, I'm going to go up by 5 units. And if they're below 200, I'll go by 2 units. Here's the reason. This says 2 to 4 units every 3 to 7 days. It'll drive you nuts. You won't get anywhere. Most of these people are probably going to need 40, 50, 60 units. It'll take you forever to get there. Most people are going to see better movement once you get to around 20 to 30 units a day. Okay, so that's just mine. You're over 200, I'm going up by 5. If you're staying right around there or below, then I'll go up more conservatively. That is just my approach. It has worked forever. It's similar to what they have, 2 to 4 units every 3 to 7, what do they say, every 3 days, until you reach fasting blood glucose target. So remember, when you're doing basal, you're looking at what is the fasting doing. Okay. So we start somebody on 10 units. 3 days later, we're going to have them, at least they're fasting, checking that. Usually for these folks, I call them. I tell them. I set up a phone meeting with them. Now, you don't get reimbursed, so you do whatever in your or, you know, if you're in a practice where you've got tech-savvy people, you can have them fax it in. Or if you're in a group that has a portal, they can send it through a portal and you can look at it. It costs you time, though. So it'll have to be however your group can bill. You can have them come back in, but it'll stack up your schedule. So however you can do it. After about 3 days, like, well, okay, how's it going? Great. Are you having trouble injecting? No. Great. Okay, good. So any lows? Nope. Okay, what are your fasting blood sugars been? 225, 270, 240. Okay, I want you to go up to 15 units. I'll talk to you again in about 3 days. That's the way I would do it, but that was my job. Here's another way you can do it, but I'll tell you, I found it difficult to get people to do it, is you can write them out a schedule. You can say, okay, start 10 units on, this is Monday. If blood sugars are less than, are remaining over 200, then on Thursday, I want you to go up to 15 units. So you can write them out a schedule, or you can tell them, I want you to increase. There's another way that people have done it, is as long as you're above the goal that you want to be in the morning, go up by a unit every morning. That was Lantis's thing. I've tried it. It works to a certain extent. Or you can tell them I want you to go up, I want you to increase the dose every 3 days until your blood sugar is 150 fasting. And I want you to go up by 2 units every 3 days. Get the gist? You will do this all the time if you're dealing with diabetics on insulin. This is pretty common. Usually what I would do is I would give them a top. Okay, I want you to keep doing this until you hit whatever, let's say we start at 10, until you get to 25, and then I want you to hold it there until you see me. And I always see these people, I'm turning them over pretty fast. I would probably never go beyond, well, usually I never go beyond a week, but I would see them probably in 2 weeks. But I'm also talking to them. Okay, so you all want to know how to dose insulin. This is a common strategy. Questions? Okay. Okay, see the little yellow, or it's not yellow in yours, in the middle, that diamond? If not controlled after fasting blood glucose target is reached or dose is greater than half a unit per kilo per day, then add a fast acting. Okay. So the oral drugs that they're on, you have them keep taking them. You don't stop them. Most of the time, I'd say the rule should be don't stop the oral agents. Here's kind of the quick and dirty I've done, is if I get up to 50 units of basal, then I'm always going to start looking at where do I need to add a fast acting. Because the problem is that these people are basal deficient insulin, so it will help. But basal insulin has no power over a meal, none. Okay? So if you're looking at their blood sugars and they're still spiking at certain times of the day, you have to put either they've got to change what they're choosing to eat, be more active around that time, or you're going to have to add a fast acting. So let's see what they say. So what they're saying, let's say you're dealing with a 100-kilo person, okay, 50 units worth. Because that's 0.5 units per kilo per day. See how they got that? I see a few shaking heads. Do you see where they got that? Okay. So then what do? Well, you look at their blood sugars. You can usually if for people like this, I still would go with once or twice a day that they're checking. Always want to know fasting, but then I start to want to know the rest of the day. Like maybe what is it before supper time. So you would have them check their blood sugar. Wherever the sugars are the highest, add a dose of bolus insulin. Okay. So usually we would add like a bolus maybe once a day. Cover the biggest meal or cover the meal where their blood sugars are the highest. Okay. How you do it, yeah, it just depends. Type 2s tend to be pretty insulin resistant. So I usually look at if the blood sugar, if you're staying above 200 to 250 before a meal, then I'm probably going to look at 5 to 10 units. Little meal, big meal. I listen to the patient. What are you eating? What are you usually going to eat? Tell me what a supper, let's say they're always high after supper or before supper, and morning numbers are still very high. So what I'm asking them is, tell me a typical dinner. I don't want to know what foods I have. Do you usually have a meat? Yeah. Okay, well tell me what kind of starches you have. Bread, common in Oklahoma. Potatoes and mac and cheese. It's like, oh my gosh, it's just a carb store. It's just a carb load. So I have a meat and I have bread. So I'm looking at, okay, what is it? If it is really a heavy carb load, and that's pretty common for them, I might go with 10. Conservatively, you can go with 5, and most people are not going to get in trouble. It's a place to start, is with the fast acting, and then you're going to adjust up from there. You may add another rapid acting dose in the day. You may end up where they're taking a rapid acting before every meal. Usually type 2s, need about a unit per kilo per day to 1.5 units per kilo per day total daily dose of insulin. Okay. So if they weigh 100 kilos, then 100 to 150 units a day is not out of the expected. Still taking their oral meds. 75% of type 2s will go to insulin at some point in their life. It's inevitable. Okay, y'all are really quiet, so I don't know how to interpret that. Is it overwhelming? Are you sitting there thinking, I'll never do this? I will avoid, never going to do it. The more you work with it, it's type 2s. As long as you are reasonable, they will not get into trouble. They don't tend to have the profound lows as type 1s. They're very insulin resistant, so they take a lot of insulin to get their blood sugars down to normal. So there's usually a lot of protection there for them and you. Okay, so if you go down the left side, add 1 rapid insulin injection before the largest meal. Here they say 4 units. Okay, that's fine. 4 or 5, it doesn't matter. That 1 unit to the type 2 resistant person is nothing. Okay, adjust it by 1 or 2 units once or twice a week until the target is reached. So what is your blood glucose target? Preprandial? 80 to 130. So that's what you're going to be looking at. We'll walk through some patients' numbers here in a little bit. So you can do that, or you can change them to a premix down the right side. If you're going to 2 injections a day, you can go to where you give them an injection of a premix first thing in the morning and then before supper. So that's why a lot of people use premix. Is they go to it after they've done a basal, they'll move right on to the premix. Here what they do is they take the dose that the person's on and they give total dose. Let's say you've worked with this 50 unit and you've tried maybe 10 units and you're not seeing what you want. You could combine that total daily amount, total daily dose is 60. And what they're saying is give 2/3 of it in the morning, 40 units, and give 20 units before supper. That's the premix. Now, if you're doing a 70-30 premix, how much basal are they getting?
30.
28 and 12. How much basal are they getting here? 14 and 6. Okay. I just don't think you all, I can't read what you're thinking. So what are you thinking? This is too hard? I'm overwhelmed? I have no idea what you're talking about?
I'm just like overwhelmed.
Okay.
Yeah, like thinking about trying to choose an insulin based on.
Then ask me questions. I don't know how to explain it differently. So I'm not making fun of you. I just can't read you in order to go back over what'd you say, Casey?
I just said I didn't know what to ask.
Okay, where did you get lost? Well, I'll just go back to that point.
I'm not like lost anywhere. I just think I need to like take time to sit down and
Yeah,
with it and go over
yeah.
it. I need a minute. Like, I'm
I
not taking it.
I'm
scared to take care of it.
You should, but I did tell you, if you're going to do insulin, work with people who do insulin. You will get familiar with it.
I feel like I get the basics of, rapid, long, that type of, but seeing like a patient's blood sugar and then adjusting dose or adding a bolus just kind of makes my head explode.
Well, and I understand it because it takes a lot of practice. So some of this, what you all need to learn right now is the science. The art you will learn as you get out. There is a lot of art, but you have to understand what the insulins are doing, okay? So you got to know basal and bolus, which are which. For the next thing is that I'm going to add insulin to oral agents. You could take them off entirely oral and put them on insulin, and you could control them. Most people don't want to do that. Sometimes it's the cheapest thing to do. So I've done that when expenses are a problem, but most of the time you just keep adding. You're going to start with a low amount, 10 units. You're going to adjust it every 3 to 7 days. And you're going up by those units that I gave you. They have 2 to 4, I say 2 to 5. It's easier to remember. Your target, what blood sugar are you monitoring? Fasting. You're going to look at the fasting blood sugar and you're going to adjust the dose based on that response. Once you get up to about 50 units or half a unit per kilo per day, and you're still not at fasting blood glucose targets, 80 to 130, then you're going to add rapid acting. You can add a rapid acting to 1 meal a day, or you can switch them to a premix where they're getting basal and bolus twice a day through a premix product. Yeah.
If you add it to 1 meal a day, does it need to be their largest meal or just whatever things can be?
Usually their largest meal will end up being the meal that's causing the trouble. So I would add it to the heaviest carb meal. I'll get it down. self-monitoring of blood glucose. Too bad. Okay, we'll come back, we'll do more of this with the type 1s as well. Let me just talk about inhaled insulin briefly. So there is a product on the market, Afrezza, is an inhaled insulin. There's been inhaled insulins in the past, they've gone off the market. The last one that was on the market was taken off because there just wasn't a big enough demand, so they removed it. So these insulins are always replace a bolus. So they still have to take a basal insulin. And they are inhaled before a meal. They're almost always used in type 1. If they have any kind of underlying lung disease, you would not use them. If they smoke, if they've got anything lung, COPD, asthma, it will change it changes the architecture of the airway, so you want to avoid it. Can cause acute bronchospasm. You have to do pulmonary function tests before you start them on it and every 6 months when they're on it. I just want you to know about them in case somebody brings them in. And I have tried using them. I find most patients, even though it sounds great, I don't have to inject myself, I just found most people in the end they're like, I don't want to mess with it. So I never found a big group of patients who would stay with it. This comes with a little cartridge holder. It looks like an inhaler. And it's got little cartridges that you put inside, and the cartridges contain a certain amount of insulin. So let's see, here's the inhaled insulin. So you see it, at least pharmacodynamically, it's very similar to the injectables. So there's the cartridge, here's the little insulin containing cartridges. They have 4, 8, and 12 unit per cartridge, depending, and they're color coded. So the person would open up the inhaler and drop one of those in, inhale it. If they're having to take multiple to hit their dose, they would have to do multiple inhalations. So if you look on the top of page 17, the manufacturer gives you a conversion. If they're on injectable insulin, they can be converted to inhaled. But you're in multiples of 4. Next page, it shows you they come in little blister packs. The blue is the 4 unit, the green is the 8 unit, and the yellow is a 12 unit. Here's the little dosing conversion. I think if people approach you about it, the things to remember is, one is, first of all, do they have any lung disease? If they do, tell them they're not a candidate. The other is that if they're going to take this, they still have to inject a long-acting insulin. And they have to undergo a pulmonary function test every 6 months. And it can change their lung airways. Nobody's used them long enough to know what 20 or 30 years we do. Questions about that? Okay. All right. Okay, let's switch over to type 1 pathophys.